Alrighty. So my first question for you is, please tell us your name and a few sentences about your clinical background and experience.
Okay. My name is Lauren Kavar, and I am an OBGYN at Skyridge Medical Center in Denver. I have been in practice for 10 years since residency, and I did my residency at Long Island Jewish Hospital in New York.
Cool. And have you attended any trainings on how to best support intended vaginal births?
Not since residency.
Awesome. So what steps do you take to minimize unnecessary cesarean births beyond 37 weeks gestation without medical necessity?
I think probably one of the most important things is actually talking to patients and counseling patients, because I think sometimes people have like a false sense of how long labor should take, and they get frustrated or anxious and, just want to be delivered if things aren't happening in as quick a fashion as they want. And so I think talking to patients and going over expectations with them that this can be a longer process than just a few hours or even more than a day. And so that they understand. And then on my part, just, being patient as well.
Awesome. When making clinical decisions, how do you evaluate and weigh the risk of mothers and babies from vaginal birth versus the use of cesarean births?
Most of the time that's going to be based on the fetal heart tracing. And if that's not reassuring, what can we do to fix it? And, trying to, again, be patient with that, not rushing to jump to the worst conclusion right away, giving a little bit of time without putting the baby in danger for the baby to recover, even if we have to stop contractions for a little bit and start over. I think a lot of it still comes down to patience with all of that too.
Mm-hmm. Mm-hmm. Let's see. All right. We're going to kind of shift gears with this next question. So I wanted to see if Corey had anything she wanted to ask before we move on to the next section.
I think so. I think we're good.
Awesome. Okay. Yeah. So we're going to switch gears a little bit and talk about patient education, preparation, and shared decision making. So this is a big question. So I might break it down into a couple of questions. So, please share how you prepare patients for labor and birth and encourage positive patient attitudes towards, vaginal births. And at what time during their pregnancy do you educate patients on cesarean births?
So I honestly probably don't talk about cesarean births with patients unless there's a reason for them to have it, like a placenta previa or a breech presentation. That wouldn't be part of my early counseling to begin with, unless they bring it up. I kind of tell my patients, I think it's a big thing now. People are asked to have birth plans, and my goal is for them to have a vaginal delivery as much as their goal is for them to have a vaginal delivery. So I don't really early counsel on C-sections unless there's a medical reason for it. That's something that would come up kind of only towards the end of pregnancy, and the reasons, and in that case, it would be just the reasons why they could end up needing a C-section. As far as counseling for vaginal deliveries, that usually starts in the third trimester. And I kind of like to go over with people options, for delivery, as far as if they want to be induced, if they don't want to be induced, at a timing that they might want, what to expect as far as how long labors can take with and without induction, and what we allow or don't allow. I talk to patients about that we don't starve them. We will let them eat as long as it's safe, or we let them be ambulatory. Try to give them lots of options to make them comfortable with what to expect.
And do you do any counseling or education on pain management?
Can I just ask one follow-up on that? So if you did have a patient who asked early on about cesarean, or they, were kind of going down that route, what kind of information or education do you provide to them to, kind of bring them back and encourage them to try vaginally if, as long as it's not medically necessary?
So, if somebody's asking about kind of a primary elective C-section, I always tell them that in the end, the decision is ultimately theirs, but that, this would not be the recommended route of delivery, without a medical reason, and go over the risks of C-section. And then while it is a, very common surgery and it seems like it's not a big deal, it still is a major abdominal surgery that comes with risks, both to, mostly for them, for future pregnancies, risks to damage to bladder, to bowel, and, risks in the future of developing abnormal placental, locations, risks of, scar tissue in the future, for difficulty with future pregnancies, difficulty with other future surgeries, and possibly even, difficulty with pain from scar tissue. So that would be kind of the first speech about it. And then, I try to get into why they want it. What, usually there's some sort of ulterior motive or reason behind why they're asking for a C-section, not just because they want a C-section. They might have some sort of fear of something or other.
Awesome.
Great. Thank you.
All right. So we'll move on to the next question. Do you discuss the risk of placenta accreta spectrum during subsequent pregnancies with your elective cesarean patients?
Yes, definitely. So, if somebody's asking for an elective C-section, that's something we do discuss, and that can be a risk in the future. And then, even with patients who have had one previous C-section, I don't want to scare people, so I don't want to try to get too into detail about it, unless we have a thought that may be, something that's happening, but I do discuss that as a risk from C-section.
Great. Can you talk about the role of your support staff in labor and delivery and what strategies and skills they have to promote a safe, family-centered vaginal delivery?
I think the nurses and labor and delivery play a huge role, honestly. And one thing that is newer that I think has been really an asset is our hospital does spinning babies. And I've seen that be a huge asset, and it's really helped. The training for the nurses has helped with getting patients into different positions and pushing in different positions, that I think has made things a lot easier and more accomplishing of a vaginal delivery. So I think having that training and having staff that's really willing to buy into this and participate and, be encouraging for the patients makes a huge difference.
Can I just ask a follow-up on that? Do they train physicians in spinning babies as well, or just nurses?
Just the nurses.
Okay.
I'm sure there's an option for us, but right now it's mostly just for the nurses.
Awesome. And so with that, do you work with doulas or midwives on the birth care team as a way to improve labor and delivery?
So doulas are at the discretion of the patient. So I do have patients that have doulas, and I'm happy to work with them. I wouldn't say it's the majority of the patients in my population that have them, but I do. My particular practice does not have any midwives. I have worked with midwives elsewhere in the past, but currently I don't.
Okay. Do you believe that this has an impact on your cesarean delivery?
Personally, I don't think it does. I'm sure in some places and for some people it could, but, I guess I kind of feel personally responsible for taking care of that and not counting on somebody else to help, lower the rate or manage it. So I don't think it personally affects my rate.
All right. And so one other follow-up question is, is your support staff, your nurses in the labor and delivery unit, are they supportive of working with doulas when they're present?
I think